So I'd like to introduce you to Leah Bunck. She's a licensed macro-level social worker based in LifeCare Alliance in Columbus, Ohio. She has worked for over a decade in the nonprofit world and program implementation in a variety of areas from HIV to older adults. Leah, I'll turn over the program to you. Thank you.
Great. Thanks, Judy. So I'll be mindful of my time here. So hi, everyone. My name is Leah Bunck. As Judy said, I work at LifeCare Alliance, and yes, we are based out of Columbus, Ohio, so right in the center of everything. Just to give everyone a quick overview, LifeCare Alliance, we are one of the largest Meals on Wheels providers in the nation. And so we service 5 counties. So we service a variety of areas from urban, suburban to rural. So we really run the gamut. For this slide, it says we serve about 8,000 consumers through our congregate and home delivery meal program annually. That number has gone up a bit due to COVID. As many of you know, our seniors have become more vulnerable or have had to stay in their homes. So we've had some more clients that we were serving. But today I want to focus on the grant that we do have through the Administration of Community Living. And I'm trying to forward this. There we go. So this is a very wordy goal, but I wanted to share it with you. And then I have the more glamorous version of it next. But essentially, our project was to build partnerships with local healthcare entities and EMS or first responder groups in order to reduce ER visits and hospital readmissions, and then to prove, how the home delivered meal system and then the other wraparound services that LifeCare Alliance offers was able to help with that, again, to reduce healthcare costs, whether to the healthcare system itself or to the municipality, the city, whoever was involved who may gain from that, or the insurance company. So we've labeled this program 60 plus. So again, it bridges the gap between healthcare and community-based services and systems to ensure the safety and well-being of our seniors. So our goal is to act as a catalyst for the growing demand of seniors, which we've already touched base on today, again, by reducing healthcare costs. So again, a more proactive, preventative measure, as opposed to reactive that might cost more for our seniors. So for the more visual people, also to help explain, here is a little flow chart. So you have a distressed senior that calls 911 for non-emergency help. This could be because they're lonely. We do see quite a few falls, but again, if we see a pattern of that, then could we be doing something to prevent that? So they call 911. Some of you might call them frequent flyers. And then the public safety agency responds. They make a referral over to LifeCare Alliance for either home delivered meals, pet care, homemaking services, medical nutrition therapy for their diabetes. We might be able to provide a rollator, a variety of different things for the client, or connect them with other services in the community. And then again, that long-term case management is established with us, or we do a warm handoff to someone that might be able to fulfill their needs if they're greater than what we have to offer. So again, just some of the objectives. I'm going to focus on objective 4, which I'll cover next, but to establish these local partners and relationships. Right now, we're really cultivating and deepening 2 of the relations we've had through this grant. That is with a rural fire station that does not have a community paramedicine person. So we are acting as that person with actually being in the fire station every other week, and we're going to ramp it up to more frequently. And then also we're partnering, you can see a picture here with a rural kind of suburban area, a police department in another part of the state. And so trying to see how that works, as well as helping them really maybe not have to spend as much time on some of these older adult issues that might be a fall, or again, a food insecure situation that LifeCare can help, so they don't have to keep calling on. So that's a big part, is the partnerships. Then from there we get MOUs and BAA signed so we can share HIPAA information, Mrs. Jones, how's she doing? She's not going to the doctor as much, her diabetes under control, whatever we can do to collaborate to best serve that client. And then also The third objective is to intervene with those services, as I mentioned. And then again, the BAA and the MOU help us to share that information with the partner that we sign. But today I wanted to focus on, and you saw it in the short description, is the data part of this. As a nonprofit and community group, sometimes we don't have the capacity or the ability to collect the data and really analyze it deeply to then tell our story. We all know that those stories of serving Mr. Powell so he can stay in his home longer, and we're able to feed his dog so his dog can stay with him, which is his best friend, is really important for funding and grants and all of that kind of stuff. But also that data tells such a story. So we have been so lucky to be awarded one of these innovation grants through the Administration of Community Living that really allows us to bring on people that can help with that. So the other major objective of this is to gather and publish data that shows that this model is beneficial to the taxpayer, and then also to those other entities involved. And then obviously we're always looking at ways that we can replicate it. So we're trying to get some longitudinal data from our home delivered meal group, but I'll talk about how we're including others as well in that study. So again, thanks to this grant, it's given us the opportunity to really invest in some other people power that we wouldn't normally have access to. So we have been able to use Dr. Lisa Juckett, who is associated with The Ohio State University here. Her background is in occupational therapy, also social work, and she has our lead researcher, and then she's able to bring on her team of staff and volunteers to analyze our data and figure out what tools to use, which I'll explain in a moment. There's myself, and then we have Dr. Hariharan Govid, and he is based out of Georgia. But he is working as our healthcare economist, which is something we didn't even know existed. But again, through this grant, we're able to take the time to explore and find that the healthcare economist is someone that can really look at the data, compare it to national levels, other local trends, and help us really be able to gather that data and that language to show people how our program is benefiting clients and others in the area, and that we can replicate it. We also have through the grant a full-time community and client liaison, which has done the outreach to the community partners and then helps to get the referrals that collects data we can analyze. And then we have a variety of other people on our team. So our grants management team, IT plays a big role because of the way that we administer the scaling to collect our research. And then we have a variety of field staff ranging from registered dietitians to nurses, to homemaking staff, to community health workers, to folks that weren't necessarily classically trained in social work, but through time have been trained and had human services roles. So we have a big team. And again, thanks to this grant, we're able to really gather that. So our team did decide for this grant to use the home frailty scale. I'm not sure who all is familiar with this, but our lead researcher, Dr. Juckett, decided this was going to be the best way for us to really gather information on indicating if what we're doing is helping our clients maintain their frailty or maintain that score or get better. You know, based on your classic home delivery meal client, which is someone 60 years or over, unable to cook for themselves, homebound, and doesn't have that kind of support, perhaps for at least one meal a day. You know, we aren't necessarily looking maybe for huge advancements in their frailty points, but if we can maintain it, that does help us tell a story as well. So we chose to use the home care frailty scale. You can see here that it measures a variety of functional and health domains. So function, movement, cognitive performance, communication, social engagement, nutritional issues, and then clinical symptoms and diagnoses. So I'm not sharing the full scale here. I'm happy to send a link out to that later on of where you can actually find the scale, but it measures a lot of those ADLs, IADLs, and again, as you can see here, other domains. So the way that we're implementing this, again, it's important to note that we're implementing with a wide variety of people, but making sure we're still getting the correct data. So we started implementing this in June of last year. So in the middle of COVID still, we still are pushing forward. We use this on our Meals on Wheels clients. our wellness clients. So a wellness client is going to be someone 60 and over who is either getting foot care from us at one of our free clinics. They get medical nutrition therapy from us. They get blood pressure screenings or just general consultation from a nurse or dietitian. So they're included. And then our help at home department, which again is homemaking and personal care. So anytime they open a case with someone 60 and over, they will also participate in the scaling. So we are administering it every 3 months. Traditionally, this scale is set up to measure a client initially 6 months and then 12 months. We really want to make sure we don't miss out on any data, and we're trying to get even more in depth. So we've decided to administer it every 3 months. Also, we originally intended to administer the scale in person every other month. So initially, in person, then by phone, then person, phone, person. But due to COVID, we've been doing it all over the phone. Based on our researcher, I'm not sure that she feels that we are getting any different results from that, but we all know that being in the home could make a big difference for what we're actually seeing versus what someone is telling us over the phone. And then again, I can send a link to this, but we use a secured website through our LifeCare Alliance website portal to actually enter the scale. So it prompts our team to enter classic client data so we can identify the client, what scale it is, and then the actual scale itself. And then again, we did some initial training. Everyone got documentation, got official training from Dr. Juckett. Then we started implementing the scale. She did monthly audits to see, okay, are these things making sense in terms of is someone way off on scaling or not? Everything was looking good. She might have some feedback for us throughout that time. And then at 6 months or every 6 months, we're doing a retrain or an update where she's able to share with the team what they've done. So from June until July, or at least partially of July of this, we've done 714 initial assessments, and then you can see the follow-ups that we've done with those folks. We have more than 12 months completed now, because obviously we've just completed September, but this is based on the data through July. And and so again, these clients are 60 years and over and then have not received LifeCare services for over a year. So we're counting them as new clients. So we do have clients through home delivered meals or wellness or homemaking that maybe got meals from us in 2015 or 2019. But if they stopped those services and didn't get them for a year, then we include them in this study. At this time too, we really were looking to really analyze and use the frailty scale on the clients that we got referred to from those partners at the fire stations and the police stations, as they mentioned. We haven't been seeing the referral numbers for those places go up enough that it would make a significant impact on this data. So we right now are using all clients that we're serving, and then hopefully as we increase those referrals, we'll be able to even parse out and analyze those clients that came through us through those partnerships in even more depth as well. Here's just some baseline data of what we've collected so far. It's not published yet, but Dr. Juckett has shared it with our team. And so I guess to summarize it, you see here, the higher the number, the more frail the person is. So you can see things, some people, it looks like they improve, but really from a data or actual significance, from a data standpoint, mobility is actually the only thing that significantly went down for our clients. Now, home delivered meals doesn't address mobility at this current time. And, a lot of our clients maybe come to home deliveries because of falls. So that is something that we're trying to figure out. What do we do next with that? And this data has been really helpful for us to make some informed decisions. So some next steps, again, now that we have the healthcare economist on and we have a good body of data, he's going to be looking at and analyzing some national level trends and data from insurance companies, hospitals, fire departments, all that good stuff. And then we're making asks to our local fire departments and police stations and partners for some of their data in terms of their call logs and things of that nature, which we're finding that's hard to get because they all record it differently. And so that's been a real barrier, or not barrier, but exciting challenge for us to navigate. And then as you saw with the frailty scale, what we're noticing is that maybe there are some quick fixes that someone could go in the home and help with to help the person not have to call 911 again or go be readmitted. So we are going to be piloting dispatching an OT or someone who is a former OT, still has the skill set, to go in and do some quick home assessments and home improvements and see if that impacts that frailty scaling for those clients that have that intervention, where we're combining that fall risk and that nutrition together. And again, this grant has allowed us to do that. So we're really excited. And then lastly, we'll be adding some new questions to the frailty scale. So this isn't, the actual evidence-based part of the scale, but this is for our healthcare economists to help us really analyze our trends versus national trends and collect some more data. So we will be asking specific questions to our clients about if they've called 911 in the last 90 days, and if so, how many times. Did the EMS or fire come to their residence? Were they transported? Are they recovering since they called? And then how is your own health since you went to the hospital? Were you admitted to the hospital? If you left, did they refer you to other services? If you're admitted, what were you admitted for? Again, at discharge, what did they give you? So this will also help bolster our body of data that we have with our clients, and then we can analyze it next to national trends. So that's all I have for that. We're, again, so happy to have this innovation grant because it really has allowed us to be innovative. And a lot of times at the nonprofit level, we don't have that capacity, funding, people, all that kind of stuff. So this is my contact. I'm happy to follow up with anyone, and Judy can connect anyone to me too. So thank you for allowing me to present.